So this patient has a pretty advanced corneal endothelial dystrophy with a low endothelial cell count. You can see the guttata there. Although not germane to the cataract extraction, he also has a right homonymous hemianopia from a CVA and significant epiretinal membranes. And that's both eyes. So he's what one would consider a low vision patient, right? Has issues. Think myopia in these patients, induced myopia. Myopic eyes read better. Also, he has a limited field. So by making him myopic, his images are smaller, and the field he does have will have a better, larger field. Myopic small images fit better. So think myopia for retinitis pigmentosa patients, advanced glaucomatous eyes with small central fields. AMD patients that want to read. If you take a 2200 eye and make it a -10, chances are they can read newspaper print without correction. So myopia can be a really good thing in our society because we read. So while I was saying all that, I did the capsulorhexis and hydrodissection, now viscodissection. Coming up 180 degrees. Checking infusion capacity, it's good. Hold the instrument short. You can see my finger is almost down to the handle here. Past the handle, I should say. And in goes the phaco tip. Position 1. A little hard to put it in sometimes, the chopper, because it's tight, but I like that. Alright, so if I sculpt without stabilizing, see how the nucleus moves just a little bit away from me like that? However, if I put the chopper there and hold it still, can't go anywhere, so I can be more precise and less likely to destabilize, I should say, a zonule. It might be marginal. Okay, so there's my first 2 cracks. Come over here, there's my 3rd quadrant removal. I like to use the chopper, as you just saw me do it, to rotate the nucleus. Kind of keeps it centered. Okay, so, and doesn't stress the zonule. So now we're ready to lift up a quadrant and take it out. That's epinucleus there, and now I'll probably just aspirate, like so. Okay. So what do we have? A bit of a floppy iris, huh? You could see that. Pupil wants to come down a little there. So let's just back into the center of the eye as we remove the nuclear segment, so we're far from the iris. That lets us keep our OVD there. Now I have a nice deep chamber here, so I've been nowhere near the endothelium as I removed these segments. If I didn't have such a nice deep chamber, I would have made 8 pieces instead of 4. To be able to remove them far from the endothelium. But I was able to do that anyway. Okie doke. Now I'm going to take the INA tip. Now if it had taken me substantial time to remove that nucleus, I'd know I'd have no more or very little OVD left on the endothelium. I'd put more in, but I know I do. See that little piece of lens material sitting there. The reason why it's sitting there is it's in viscoat, which is good. Now in these cases I'll normally leave that coating of endothelium with viscoat, but watch the IOP post-op because it could spike. But I don't want to go up there and start aspirating stuff. Now that little piece of nucleus, that nuclear chip, I will aspirate, like so. But all the rest of it on the endothelium I'm going to leave. Little subcapsular epithelium vacuuming, and we're ready to put the IOL in. Little PSC, rubbing it off with the OVD injection. That's Provisc. And now the IOL insertion. Wet the cornea, please. Notice how when you wet the cornea, the stria induced by the cartridge tip become less obvious. And you see better as the IOL's inserted rather. That's kind of standard for me just as I begin to inject the IOL to ask the technician to wet the cornea. Okay, so we do want to remove the OVD from behind the IOL and in front of it too, but not up near the corneal dome. Yeah, super deep chamber here. So that's advantageous for the procedure in this eye. Any eye really, but an eye with significant corneal endothelial dystrophy, even better. Okay, now your next judgment is, do I irrigate viscoat from the angle? And the answer is gently. You don't want a pressure spike, but you don't want to traumatize endothelium anywhere. So that's a little bit of a compromise from the usual more aggressive irrigation of the filtration angle. Okay, and that's our procedure, and the IOP will be checked in 1 hour.